We're going to go ahead and get started so we don't get too far behind. I'm Doug Ensley, and just want to say a few words of thanks and take care of a little bit of housekeeping. This is my partner, Dr. Banyasi. Appreciate everybody being here. We're excited for these presentations. So just a few housekeeping items. All of the sessions will be here in this room. There aren't any breakouts. There will be microphones available out in the audience for questions during the panel discussions. We're extremely appreciative of our industry partners, and industry partners are welcome to join us here in the room if they haven't found their way in. For note, the glass doors at the entry across the way here, those will be locked, so if you wander out to the parking lot, for example, there's a phone number you'd need to call to get back in, but those doors are closed for security reasons. Make sure I hit out the highlights they've given me. Breakfast, snack, and lunch are out where you saw them. There's going to be drinks available all day. Reminder to silence phones. If we don't have enough food for you, which is unlikely, there is a cafeteria upstairs one level. If you have any questions today, we have lots of assistants in the pink Heart and Vascular Institute shirts. The Wi-Fi is guest access. You won't need a passcode of any kind. I'm obligated to read this, and I've been instructed to read it sort of verbatim. CME is available for these sessions through something called CME EFI. It's a third-party vendor. It's outside of our education department. Your packets have instructions for how to use that with QR codes. Each of the topics has its own QR code, and you can go out, fill out an AI-guided reflection, and receive your CME hours. If you're joining us virtually, let me get back on these instructions. A link to each survey will be provided in the chat box of the virtual session. And all of this will be available to the end of May to complete the process. If you have any questions about the whole CME thing, Allie is the CME queen. So if you have any confusion about how to capture your CME, check with Allie. Just want to again say thanks to everybody who put the program together. Dr. Banyasi and I are here, but really Dr. Hernandez put together the amazing program of speakers from around the country, and we're grateful for him to doing all that work. But first and foremost, Tracy Boland has just done countless hours to pull this off, and so huge thanks to Tracy and all of the staff from the education department for putting this on. And I think I've accomplished my job. Dr. Banyasi may have a word or two, and then we'll jump right into the first session.
Thank you, Doug. I'd like to start and echo what Dr. Doug Ensley said about thanking everybody here and welcome everybody here, and welcome our speakers and welcome our session chairman, which is their scientific background and their scientific expertise certainly will help us to have a successful program today. I would like to thank the industry for our industry partner for their support for such kind of symposium. Without them, we wouldn't be able to run such kind of meetings. I would like to thank the audience. Without you, we wouldn't have a meeting. That's a great pleasure to have all of you here. I would like to thank Dr. Doug Ensley and Dr. Hernandez for their leading the scientific program, and they did a great job in putting that together. I would like to thank our local organizing committee for helping us to have organizing such kind of meeting. Cardiogenic shock remained one of the most challenging and complex, rapidly evolving area in cardiovascular medicine. Despite remarkable achievement in MCS, in transplant medicine, in critical care medicine, the morbidity or mortality of those patients remained unacceptable high. And what makes it different than other disease problems, that's here, it's an intersection between multidisciplines, and no one disciplines own that cardiogenic shock. It's a multidisciplinary approach or multidisciplinary complex issue. That's requires heart failure cardiologists, requires interventional cardiologists, cardiac intensivists, CT surgeon. It requires a village of people to be able to help improve the outcomes of this patient. No single specialty on that. That we have to understand that, and we have to be able to work in a collaborative way together to improve the outcome. But beyond science and technology, I think it's critically important to remember, and beyond our discussions regarding escalation, de-escalation, unloading, and clearance of lactic acid and so on, there's a patient and family beyond that situation, and facing the most challenging decision in their life when they are in that situation. We shouldn't forget about that. And I think with that said, I hope we will have a successful meeting today and lovely discussion. And I will give the microphone now to the chairman of the session to start officially the scientific program. Thank you very much again.
Good morning. My name is Bob Garrett. I'm one of the cardiovascular surgeons here. I'm the moderator for the first session. There'll be 4 talks. In the case presentation by Dr. Murley. This is Dr. Anderson Murley from Bartlesville. This is Dr. John Stewart, who's one of our intensivists here, works with Dr. Vaniosi. Just on a personal note, I would say we've been treating heart failure for years and years, but the tools we have now are incredibly better. Medically, it's 10 times better. The MCS tools we have now are incredibly good. It's a very rewarding profession, very rewarding specialty. It's also humbling. There's an old saying, you can't save everyone, and that's very true, but we now have people that they can see their grandchildren graduate, they can spend time with their families, they live a few more years. It's absolutely invaluable to these people. Their quality of life is better, and generally they live longer. So we're very fortunate here to have some of the best people, not just in the country, but in the world, with heart failure and MCS care. And one of them is Dr. Hernandez, the first speaker. He's our head of our heart failure cardiology, and he's going to talk on cardiogenic shock profiling.
Thank you. Just trying to put this. This one?
You can hit next.
Next? Okay, perfect.
Sorry. Again.
Perfect. Thank you so much. Well, I'm very excited to be here and welcome everyone to this shock symposium that it's been really built by Dr. Ensley and Dr. Ali Banajosi, and I pretty much was welcome to add some perspective to it and bring some speakers that I consider people that I admire or their friends or that have some connection with our trajectory in research or in education. So very, very grateful for the opportunity to be here, talk about profiling with the concept of not just profiling towards the next day, but really profiling towards longitudinal well-being. So we know that cardiac shock is a complex disease entity. Escalating inotropes and vasoactive devices have an increased mortality. We have seen this across the years in multiple registries. And this transition from a hemodynamic to a hemometabolic problem really requires a team, as Ali was mentioning, to try to understand the risk of these patients beyond their disease, with a lot of emphasis in the non-modifiable risk factors that have to do with social determinants of health and the impact of cardiac arrest that will lead to these patients to have a completely different trajectory. Of course, it's a complex but actionable disease, and really the idea is try to avoid being in this situation in which we have mechanical ventilation, inotropes, vasoactives, renal, hepatic injury, very high bilateral loading conditions, and multiple stacked devices in the next few days, because these patients, we know they have the very high mortality in the hospital and the lowest possibility of going home with their own heart. So really pushing teams to make a decision for heart replacement with very little time to create those pathways. We're going to talk a lot about shock today and trying to really untangle this heterogeneity situation. But we have a lot of work to do just before we will say cardiogenic versus distributive versus hypovolemic, mixed, and then we profile them to ischemic or non-ischemic, and we'll see that in the non-ischemic world, there's a lot of subphenotypes that we're going to be looking at along this course of the next few talks. And I will say, despite the fact that there are few trials that are positive, particularly in the non-IMI world, I think we have made a lot of strides. I mean, thinking about where we were 20 years ago, for example, in this a picture that I found in the place where I trained and I worked a long time ago in Massachusetts. You know, before it was really this single physician, nurse trying to battle cardiac shock with their very sick patients across the night, in which a lot of patients were just only on inotropes, vasoactives, perhaps a balloon pump, which is a low-profile circulatory support device, mechanical ventilation, renal replacement therapy, in this sort of unidisciplinary model of care, with absent hemodynamics, no transitions for these patients, absent palliative care, and I think we have made a lot of strides in our management of these patients from that time to now. Of course, we have different acute mechanical circulatory support options, and the things to consider is what is the transition, the phenotypic responsiveness, the heart recovery capability, the hemocompatibility, and a really focus on the vascular safety and avoidance of complications. I think this is one of the reasons why perhaps recurrent trials continue to be negative, is that we haven't really been focusing on profiling, particularly, for example, in this ECMO ECLS shock trial, in which, again, the majority of the patients have advanced levels of severity. Many of them had cardiac arrest before randomization. So really has made us think about the value of profiling patients and including those patients in the trials at earlier stages. We're very proud, since we represent the cardiac shock working group, to see that the only positive trial in shock, which is the danger shock for acute myocardial infarction, did include our classification. And as you can see down below to your right side, you know, there was a proportion of the majority of the patients being on early SCAI stages versus advanced. But there's a lot of work to do. The majority of the real-world cardiac shock patients that are receiving temporary MCS really lack direct RCT evidence for their management, particularly on the trials that we know that are represented in the IMI world. And again, when we compare the trials with the registry, there's still a lot of misrepresentation. In that context, it requires a lot of interdisciplinary judgment and understanding of why are we putting devices, whether it's early benefit, whether it's stabilization, or it's just salvage because we don't have an option, the patient is going to die in the next few minutes or hours if we don't do something about it. So that is very important in terms of communicating with the nursing staff, with the patients' families, with the patients in itself, of course, being the center of everything if they're not intubated. But again, this concept of understanding what are the expectations of our decision-making becomes very important. In that context as well, we have found certain aspects from registry data that really impact the longitudinal trajectory, whether it's recovery or heart replacement. One is the impact of limb ischemia in survival that really points out the value of having vascular excellence when we're doing percutaneous support, but also highlights the importance, and that's why we have here Bob, we have here Nate, that are going to tell us about the value of having surgeons with expertise in mechanical circulatory support in order to avoid a lot of these complications that are related to limb ischemia, and the value of having them part of the team and on that decision-making process. Of course, we will always like to see high-profile percutaneous temporary support in this regard with, you know, vascular excellence, protection of the limbs, but that doesn't happen all the time. And if these patients really require, again, an interdisciplinary approach for escalation and for high-profile support, but also protocolized management for troubleshooting and complications, particularly with device positioning, particularly with making sure that from a vascular standpoint, we don't have bleeding-related issues. The other aspect that is very important from the registries is the access to hemodynamic profiling. Hemodynamic profiling has really changed the way that we approach these patients early or as earlier as possible, and has really changed from this wet and cold environment or wet and warm environment into a more dedicated perspective on how complete assessment of hemodynamics impact in different levels of severity the trajectory of these patients in cardiac shock. We have now really advanced ways of understanding what is a problem, whether it's a left heart problem, a right heart problem, or a biventricular problem with the use of PA catheter. Again, part of this work, we're very proud because we collaborate with Dr. Sumner, which is here in the audience. He actually did this review of the literature and published this hemodynamic assessment chapter for SKY. And again, it's how we translated that knowledge into the bedside. Here we have Dr. Carrington that is going to talk a little bit about other aspects of shock in that context of translating that knowledge into a bedside. He was able to basically create this infographic for the bedside so we actually have the right data. It's very important to have the right data because if not, all the derivations and expectations that we have from machine learning, from big data analysis, will not be accurate if we don't have the right data. So I will say that in the last 2 months of me being here in San Francisco, I think Dr. Ensley and Ali and the whole team in the CCU with excellence in nursing, I will say, from a hemodynamic standpoint, we have very accurate data. We have the possibility to truly recreate the recommendations from the ACC to then create, registry information that can help others create a real-world data to machine learning analysis. When we think about shock working group, this was the first analysis, and we were thinking about right atrial pressure that was associated with worsening mortality. We have very simple analysis, as you can say. Right heart congestion in shock is bad. The value of having right heart cath before temporary mechanical support. We were able to see this first analysis in terms of the impact of biventricular congestion in shock. But then from there to now, we have advanced hemodynamics, such as aortic pulsatility index, such as pulmonary artery pulsatility index, that are really related now with specific outcomes, such as native heart survival in specific phenotypes like heart failure-related shock. We have other also advanced derived hemodynamics we're going to try to incorporate in our flow sheets, which is a BPRI that divides mean arterial pressure versus vasoactive inotrope score. And again, that's also something that can help us or orient us understand if these patients are ready for explant of temporary MCS. So these two novel hemodynamic parameters can be derived from the PA catheter, can be incorporated into your flow sheets, and can really educate the team and the interdisciplinary team if whether these patients are ready to be weaned off or not, and are clinically intuitive. Again, the concept of hypotension, hypoperfusion, treatment intensity was taken into a more granular analysis, thinking about SKY stages being a semantic, more qualitative way of classifying shock. Now we really can quantify it and understand in the different trajectories that these patients follow. We have seen the adoption of these severity criteria in the trials, as we mentioned, and in the recent consensus from the ACC. But there was something missing here, which was the impact of cardiac arrest. I think a cardiac arrest patient that is at a SKY stage E is very different from a patient that is SKY stage E without cardiac arrest. We have seen double or tripling sometimes in the mortality, particularly when it's in-house, particularly when it's happening in our watch in patients with heart failure, cardiac shock. So the new classification, which is right now in review, includes, as you can see, a modifier for cardiac arrest at the end. It has been simplified in order to try to really translate this to the bedside, to the frontline clinicians: hypotension, hypoperfusion, treatment intensity, 3 main variables like systolic blood pressure, lactate, and the treatment intensity that are easy to understand, easy to translate. And again, it will simplify algorithms that we have developed, which I think have been very valuable, such as the Salud protocol that we had at Baylor Scott and White. But it's really important to think about, sky staging not being something just for physician scientists that love shock and love registry data. Is more like we're trying to really translate it to the bedside. And I think this new classification is very helpful, particularly for our transfers. Transfer is a big problem in the shock world, of course, because there's a time-sensitive interval that is added to those to occur for those patients. We have a lot of work to do to try to create a network of care across Tulsa first, and then across the state, in which we can find some, increased situational awareness to try to solve this sort of massive geospatial challenge that we have. In terms of getting these patients early, not at Sky Stage E with cardiac arrest, which will be the main goal, this golden day that we have talked about, this really, this very simple but important idea of avoiding the cardiometabolic phenotype in which bilateral loading conditions, renal and kidney function are already impacted. Again, this is very important, understanding these very simple, non-congested cardiorenal, cardiometabolic phenotypes, because again, are impacting our understanding on trials, even if the trial is positive. As you can see here, mortalities, duplicate on those patients that are supported in the DanGer trial, for example, that were profiled with these phenotypes. You can see that cardiometabolic goes from 25% to 65% mortality. And I think that is a very important message in terms of the value of early recognition, early intervention. Again, these patients that start on E and they don't change their trajectory within the first day, and now we know within the first 6 hours, they will really struggle to change their trajectory towards survival and even what we expect, which is native heart survival. One of the things that I think were a little bit disappointing was the fact that this trial was actually not conducted, but it's something interesting for the future, and I think some of our speakers are going to talk about, which is the value of having algorithms for management of shock. We know how to recognize, we know how to profile, but really having dedicated management, protocolized management for hemodynamic assessment, device escalation, management targets, device de-escalation, and explant. And I think here, for us in San Francisco, I think that is the next level. I think the recognition portion, the data acquisition portion is excellent. Is now how we can have protocolized management for particularly device escalation and management targets. Again, a lot of what we're going to talk today is the different phenotypes or subphenotypes of cardiac shock, heart failure shock versus non-IMI versus IMI. The idea is to start thinking not from a device standpoint or device-specific standpoint that is either ECMO or Impella or balloon pump, but really in a more clinical perspective of perfusion, decongestion, resolution of end organ dysfunction, achievement of hemodynamic goals on patients that are being ambulatory, educated, and having improved nutrition and psychosocial mental health. So then we can think about weaning, hopefully, and if they don't wean, consider heart replacement. And just to finalize a few more slides, it's important to understand that the patients that we see in shock and have a specific classification, SCAI C, D, or E, they also have a background of comorbidities, and they're sort of, that's where, public health and overall health in general of our population that we care for becomes very, very important, and is completely connected with cardiac shock programs. As we can see, patients that have an increased level of comorbidity have worse outcomes despite having similar SCAI stages or similar level of severity. I think that's very important, particularly when we're making decisions for transitioning these patients to heart replacement versus heart recovery. A lot of these patients, perhaps the option that we'll have for recovery is being blunted or affected by their number of comorbidities. It's very important to have access to transitions in heart replacement. As we can see, when patients don't have the access to a heart replacement, their mortality, doubles or triplicates as well. I think for us in San Francisco, we're very excited to think about the possibility of adding as a heart replacement strategy transplantation. in addition to LVAD. But again, the main goal for these patients will be to consider native heart survival first, but if that's not acquired or that's not possible, really think about the possibility of replacement. In terms of transplant versus LVAD, more and more data continues to emerge that at least in the short term, a lot of these patients that are in a young age, between 18 and 49 years old, will have a similar survival within 2 years, opening the door for a better heart transplantation trajectory and an increased net prolongation of life when you bridge these patients with an LVAD, particularly these patients that are not ready from a comorbidity standpoint, from an end organ dysfunction standpoint. And a lot of the things that we've been doing and working here with Ali and the team in the last two months is trying to match these mechanical unloading platforms now that we have high-profile support like Impella 5.5 with LVAD. Trying to go directly versus going balloon pump, ECMO, LVAD, really going from inotropes to Impella 5.5. I think we have some degree of data that suggest that this might be beneficial from a complication standpoint and from a better success for transitioning to heart replacement. A lot of this has to do with physiology at the end of the day, really trying to understand the responsiveness of LV unloaded with the pulmonary artery compliance impact, and then eventually how that impacts the right side of the heart. Many hearts have been recoupled with biventricular shock, that in many algorithms, the response will be BiV support or ECMO, now are being really rescued from a right heart standpoint with left ventricular high-profile LV unloading. We talk about the value of really having this minimalistic single organ approach. This is from our prior program where Jeb and Osama take care of these patients in step down, in telemetry basically. And just to finalize, I think the idea of transforming cardiac shock from a single entity that has to do with a 30-day survival, now we're really thinking more of a chronic disease management program in which we talk about remission, we talk about recovery, but it doesn't end on the hospitalization. It really starts in the hospitalization, and the whole idea is to continue to see stories like Frank's story that, again, if you listen to this interview, he's just talking about a program. He's really not talking about physician. He's not really talking about a device. He's really talking about a program that helped him be where he is right now. So with that, again, thank you so much for being here. We welcome you, and we're very excited for this shock day as well. So thank you again.
Benyosi, he's head of our intensive care unit, takes wonderful care of all our MCS patients, and he will talk on cardiogenic shock networks using data to help patients.
Thank you so much. And it's my pleasure to be with you here today, just to start to talk about my journey and my journey with St. Francis and what we have been able to accomplish here and elsewhere, and how we utilize data to help us to grow and help us to also to improve outcome of our patients and building networks. That's my disclosure slide. How I can get the slides here, please? It's only here.
Oh, yeah,
They are here, but not here.
interesting. I don't know why it's...
Anyway, I can keep talking and while you do that.
Okay, let's see.
Well, that's my personal background. I was in Germany for more than 28 years, and I'm a program builder, built many shock programs, many VAD programs, many ECMO programs, also retrieval programs. I'm doing that since more than 25 years. And it was my pleasure to join St. Francis team because we found that we are aligned in a vision. St. Francis had the vision to build and reshape their Heart and Vascular Institute to be a leading cardiovascular program in the area. And what I'm going to talk about now is to show you for the first part for my presentation, the challenge we have in management of cardiogenic shock and why there is a need for regional networks in hub and spoke model. And the second part, I'm going to show you how we utilize data to help us to grow and help improve outcomes of our patients. The challenge we have with the cardiogenic shock, as we heard also from Dr. Hernandez, the mortality rate is still high, and the number is still in a rise. And if you look at that, here is still data from Mayo Clinic showing that patient admitted to the SICU, there was increase in the number of patients admitted with diagnosis of cardiogenic shock in a SICU from 2007 to 2018 by 21%. That means we still have a big problem. And we heard from Dr. Hernandez about how to start to phenotype such kind of patients. This data here, published from my previous work in Oklahoma City, you see that we published our first 184 patients we supported with the ECMO from inside the hospital and from the network we built. And you see that we're talking about how we phenotyped and how we classified those patients. About 21% was acute MI shock. And if you add the in-hospital cardiac arrest, which is about 14%, that means 35% was related to acute MI shock. That's many other patients was not related to acute MI shock. It's a post-cardiotomy cardiogenic shock or acute on top of chronic. That is important. See, we are dealing with heterogeneous group of patients. Other problem we're facing is that there is many phenotypes are underreported in literature. That's the case here for 15 years old female patient with severe DKA, complicated by PFib, secondary to severe metabolic disarrangement. She was placed in the ECMO under cardiac compression for 6 days and recovered. Such kind of phenotype, you don't see them in it's underreported. And there's a bias in the literature reporting more acute MI shock in the past. Now we start to talk about more heart failure, cardiogenic shock. But there's also other phenotypes we're not addressing them. Well, also the classification, and in the past we were putting all patients in one group and say cardiogenic shock. Patient with lactic acid of 3 in the same group like patient with lactic acid 12 or 14, and all of them are cardiogenic shock. I'm glad that and Dr. Hernandez, a key player in a cardiogenic shock working group, started to stratify this patient, classify patient in cardiogenic shock. And we see that the outcomes also varies according to the degree of shock they are having. That's very important. The starting point to see utilizing data to have the same language is important. Also important to know that most of patients with acute MI shock are treated outside academic institutions. It's not only in acute MI shock, also coronary artery bypass grafting are treated in small hospitals. And this small hospital usually does not have infrastructure. If something happened, patient in advanced cardiogenic shock, to have 24/7 support and adequate treatment for this patient. That reflects why we have to work in a collaborative way between hub and spoke center to be able to transfer a certain patient who requires such kind of advanced care to the hub in a timely way. Also, times matter. We'd like to get the patient as early as we can to prevent the spiral of the problems will be associated with the underperfusion. We would like to achieve the patient early before the point of no return will come in advanced cardiogenic shock and you have high lactic acid and severe multi-system organ failure. Despite what you're going to do, the patient will not recover because that's still this started to happen. Well, also team approach, because we know that how complex the case, the syndrome is. It does not need one discipline to treat this patient, and this data is showing that multidisciplinary approach is improving outcomes of this patient. Why we see variability between outcomes between centers? Because many of the cardiogenic shock patients are treated in a fragmented way. They are delayed. We have delayed recognition, we have delayed transfer, and in variable protocols, we are not applying standardized protocol, and reactive decision, always late, always behind. Those patients need a comprehensive care, early recognition, multidisciplinary approach, early escalation, standardized pathways, and data-driven decision making. Well, we see that, I'm glad that American Heart Association started to recommend that treating patients in advanced cardiogenic shock in a hub and spoke model, regional hub and spoke model. And why is a hub and spoke is important? Because from my opinion, it's improving patient outcome, offering access to advanced care to those in resource-limited areas. Again, that's outside the academic institution and small hospitals. Cardiogenic shock is happening everywhere, and we have to open the access for those patients. Help to grow other programs, because it's helping to grow the hub, expand care geographically, and strengthen network, that's to say partnership with others as well, and enhance education and spearheading innovation. Well, how we are using data to help quality improvement and growth and also helping our patient. I'm going to show you here that data is very important. Without having data, we will not be able to improve outcomes. We don't know what's our quality of work we're doing. We do believe that we are having a great job, but who can prove that? Without data, there's no move forward. And I'm glad we have now the cardiogenic shock network. We have different registries. We have the American Heart Association registry, cardiogenic shock working group, which is Dr. Hernandez is the key player on that. And we have the National Cardiogenic Shock Registry, ELSO registry, and there's outside the United States, we have two. We have the French, and from Denmark, we have the Danish registry, which was the basis for the danger shock trial. But beside that, it's as critical important to participate in the registry. You have to have your own data, because that's going to reflect how you are performing. And without this own data, particularly if we're working in a field which is utilizing a lot of resources and time intensive and time demanding, we have to prove that what we're doing is helping patients and also have high quality. And historically, that's here my data I published from my time in Germany, which was 2005, which we have also multidisciplinary network to save lives of severe resistant cardiogenic shock patients. That's my first 50 patients in Germany, which we have in a cardiogenic shock network. And without having our local data bank and registry, I wouldn't be able to get this data and to prove to the administration that our outcomes is okay, is good. We're using a lot of money, a lot of dollars, a lot of euros at that time, but it's helping patients and helping us to grow as well. We were at that time in Germany, we were doing about 5,000 open heart surgery cases in our institution. That helped us to grow, to get the patient linked to us. And outcomes, you see, we're not mentioning here 30-day survival or 6-month survival. We have 50-month survival, about 50%, and also no difference between acute MI shock versus non-acute MI shock. That's without having data. You will not be able to present that. That's the American Heart Association registry. Is very comprehensive, which I'm glad, and we are from San Francisco, we are participating in that. We're trying to see that comprehensive registries are coming, and will helping us also to see how we are performing compared to the others, and helping to move the field forward. Well, what can, from our local data bank, what we are collecting from data? We're collecting from, and we limited our data bank here to the patients who on temporary mechanical circulatory support for in-house, or we are retrieving them from the area. We are collecting pre-implant and post-implant data and implant data. We're collecting demographics, clinical data, hemodynamic data, lab data, imaging, and device-specific data, and we have bi-weekly data meeting to educate this data, see what we collect is okay. And that's collecting from all patients coming to us from referring center. That's modified from my previous work in Germany. We are working in how we build the hub and spoke model. We have the hub, which is accepting patient in cardiogenic shock, was not, the other center does not have the capability and resources to treat them. We're accepting those patients in hub. And we're building that in a streamlined fashion. That means we have shock hotline, and that shock hotline is always busy with carrying one of our partners, one of MDs, is going to get the call from the referring partner and and discuss the case, accept the case or decline based on facts about the patient. We discuss also the exit strategy, not only discussing the patient and accepting, also discussing the transfer. Some patient will be transferred by their referring center because they are stable enough. Some other patient are unstable and not safe to transport them. Our team is flying or driving there to bring them to the hub center. Well, and we are also have referring criteria when we're doing outreach. We are sending this referring criteria to them, and that's also moving target because when we started with that, there was no sky shock at that time. We give them some simple data to help them to understand which patients they can refer. And that, again, is moving target. When we get more and more data, we are also modifying our referring criteria. And we have also transport algorithm based on how sick the patient is. As I mentioned, 2 sick patients, 2 ill to be transferred, we're going to them. Less sick patient, we have different ways to transport them. Also, we have a significant part from patients referred to us in a post-cardiotomy cardiogenic shock, which is the most complex cases you can manage, you can treat on this. We're getting patients from the operating room transferred to our institution. And that's the case here with this patient, the same. That's the case from the picture from this patient we transferred from outside hospital. That's here 11 days after he was on ECMO, weaned and sitting in a chair. And we also were accepting, during my time in Penn State, we're accepting patients from intercontinental transport. And we built the shock network in Oklahoma City, in Integris, and you see here we've got patients from 5 other states around us. And looking also to quality outcomes. When we started, and that's we are intensivist-led retrieval program, which is not run by, not cannulation is done mainly by intensivists, not CT surgeon, as is usually in the case. And we start to look, is that intensivist-led, is the outcome is the same? Do we have more complication? Do we have less complication? That you see that data from 2019. We are now many years after that, as we have other centers doing that. But at that time was very important to us to say, helping us to get credentialing, helping us to say that's working, and helping us to say it is safe to do such, to cannulate in this way. And here we published also when we get more and more data, and we published the data from our retrieval program, and we look to the what's the outcome of this patient we retrieved. All of them are dead after 30 days, or we have some survival, and and what's predictors of survival. As you see in a VA ECMO patient, we have about 40% survive to discharge. And those patients, if you look to the lactic acid here, probably the average was about 7. And there's this extremely sick because the transferring center was not able to transfer them to our institution. That's very sick patients. SOFA score, you see that about 13. And SOFA score of 13 is associated with mortality about more than 80%. And we achieved survival rate of 40%. Also, when looked also to the data with post-cardiotomy cardiogenic shock. Our post-cardiotomy cardiogenic shock, we're bringing them to die in a hospital, or the patient are surviving. If you look to that, we look to compare the patient who we retrieved from outside hospital in a post-cardiotomy cardiogenic shock and compare them with in-hospital patient struggled from severe post-cardiotomy shock. And you see that patient retrieved had lower mortality, but still acceptable. Even in a patient, we know that post-cardiotomy cardiogenic shock had very high mortality, and you are achieving here 49%, almost 50% survival. That's a great save. Well, I'm very excited about the future because traditionally, we are treating patients, start to treat patients when cardiogenic shock started, when lactic acid started to go up, when they start hypotension. In the future, I'm hoping that with the machine learning, we will be able to predict cardiogenic shock and to start to treat the patient area. And I'm going to show you some data from Johns Hopkins. When you look to 24,000 patients admitted with acute decompensated heart failure, and 265 patients developed cardiogenic shock, and did retrospective analysis using simple data, vital signs, lab values, and medication administered during hospital stay. And they have been able to identify patients who were at high risk to develop cardiogenic shock versus patients who were not in a high risk based on their model. Patients who were at high risk to develop cardiogenic shock had 10.2 times higher prevalence of cardiogenic shock. Yeah. And that's my last slide. And beside that, the system was able to identify that 1.7 days in median earlier than we started to treat them. That's the future, how to identify patients early before that happens and how to treat them. That might revolutionize the management of cardiogenic shock. That's my conclusion slide. For shock networks to function effectively, we need both standardization and data infrastructure, but classification alone is not enough. That modern shock care generates large amounts of clinical hemodynamic and laboratory and imaging data. To use this data effectively, networks require registries, real-time dashboards, electronic medical records integration, and multidisciplinary review system. Traditionally, we intervene after clinical deterioration has already become apparent. However, AI-driven system may soon help us identify subtle physiologic changes long before overt shock develops. Thank you so much for your attention.
Thank you, Dr. Banyosi. The next speaker is Jonathan Stewart. Jonathan's one of our intensive care unit specialists here, does a great job. He is speaking on mixed cardiogenic shock, untangling the spiral of heterogeneity.
I think that's you.
Perfect, thank you. Thank you, and good morning. We'll spend the next few minutes expanding on the concept of phenotyping patients with shock by covering some high-level concepts regarding mixed cardiogenic shock. And simple guy, I like to keep things simple to begin with. At its core form, mixed shock is the presence of cardiogenic shock plus at least one additional shock phenotype. And an additional shock phenotype can take many forms, but it most commonly takes the form of vasoplegia or distributive shock, meaning low systemic vascular resistance, aka low SVR physiology. If you pour through resources, you're going to see, though, that there's no uniform evidence-based definition that exists. And that's because of the heterogeneity of this patient population. We've talked extensively about heterogeneity in single shock phenotypes like cardiogenic shock alone. It becomes even more complex in patients who have mixed pictures. And the heterogeneity of mixed shock creates a profound diagnostic and therapeutic challenge, and that's because standard shock protocols are ultimately designed around a single phenotype. And it may, in fact, end up being harmful when we start applying algorithms to patients who have mixed physiology. Right? We run the risk of misclassification, where we fail to recognize and identify coexisting mechanisms that may exist with the primary dominant phenotype. We run the risk of amplifying mortality, and we face many therapeutic conflicts in that treatments for one shock phenotype may in fact be harmful or detrimental to another that's present in any given patient. So we have a gap, and as Dr. Hernandez mentioned, we've had a good evolution of our thought process when it comes to treating patients with shock, from the simple early days or entry-level resources where we look at bracketing out shock very neatly by subtype into different tables, to the old warm and cold and wet and dry approach. But it's important to recognize that mixed shock will never neatly fit into any given box. Even as we evolve our classification systems, it will remain difficult to fit mixed shock into any simplified classification system. And that's because if you dive back even as far as a decade and look at important and sentinel trials, you'll see one common theme. That is, there's often limited hemodynamic qualifiers in these trials, and that's the product of having to create inclusion criteria that work for a study. That's the product of having to make guidelines that are practical and simple enough to be applied at the bedside. But it's going to remain challenging when you have highly variable patients with mixed physiology, because they're going to defy simple qualifiers. We do know some things from data registries and past trials, and that is mixed shock is out there. It's more prevalent than we would like, and it's important that we recognize and treat it. Right? It has a higher mortality risk than cardiogenic shock alone. Up to a third of patients in some of these trials have mixed physiology. Up to half of acute MI cardiogenic shock admissions will develop some form of low SVR physiology over the course of their admission. And of those that are treated with mechanical support devices, 1 in 5 will have upgrade requirements, possibly due in part due to unrecognized mixed phenotypes in initial presentation. It may be that the failure of some past trials was due in part to the presence of mixed physiology that may have gone unrecognized during the original studies. So as we evolve, we have to also recognize we need to evolve to evaluate mixed shock better too, all right? Ideally, we find a way to utilize our current hemodynamic data and qualifiers and develop optimal hemodynamic profiling and phenotyping that probably involves some combination of etiology, patient characteristics, hemodynamics, hemometabolic data, and so on and so forth, and find a way to translate all that complex challenge into a practical approach at the bedside. And we're doing that much better with our single phenotype cardiogenic shock protocols, as Dr. Hernandez was just discussing, but this remains rather elusive and challenging for patients with mixed shock. We do know a few things, though. One is that we can best treat these patients with invasive hemodynamic monitoring. I recognize we have people here who don't work in the contemporary CICU where Swan-Ganz catheters are used frequently, but it's important to recognize that although they may not help in improve general ICU outcomes, they continue to have a very important role in patients with cardiogenic shock, and their key role in patients with mixed shock is that they help early recognition of the mixed phenotypes, and they improve phenotype-guided decision-making. It's also important to recognize that mixed shock will be a continual evolution of hemodynamics, and being able to recognize that in a timely fashion in real time and adapt our treatments is critical to treating this patient population. You'll hear all about different ways to profile today, how to interpret different values, different quantifiers. The reality is in mixed shock, these can be highly variable depending on the competing physiologies that occur. I think the key point I would stress is that recognizing evolution or reversal of expected hemodynamic findings or expected responses to treatment should key us in that the presence of mixed shock may be occurring. Escalating hemodynamic support should also trigger us to recognize that that could be a signal for multi-mechanism failure. And so making sense of all of this data and all of these hemodynamic qualifiers, we should look first at the trends. I would stress too that there's many limitations to any piece of information that we're interpreting. And going through all of them is well beyond the scope of a short discussion here today. But taking some of the high-level important ones like flow, perfusion, systemic vascular resistance, it's important to recognize there's much more to the picture than any particular piece of data we interpret at the bedside, right? MAP can hide profound vasodilation. MAP can hide profound low cardiac output. SVR has many limitations as well, right? Normal SVR does not equate to good perfusion. And the point I'll make here is that these are all global macro hemodynamic assessments of our patients. And there's much more to it than that, right? It doesn't incorporate other considerations. These are averages. Averages can hide extremes. There can be extreme differences in regional flow for patients. And depending on where that regional flow is, those differences may affect different organs in variable ways. Some organs are well autoregulated against changes in flow and changes in SVR. Others are not. The gut, for example, is highly vulnerable to these changes. So you've got a global macrohemodynamic numerical assessment, but you have to take that a step further in our conceptual evaluation and treatment of patients and recognize the regional differences. You have to then take that a step beyond and recognize that microcirculatory dysfunction could be occurring. We know in patients with distributed physiology from sepsis that they often end up with microcapillary dysfunction, mitochondrial dysfunction, so even if cells are receiving oxygen, they may not be able to utilize it effectively. So even if you have adequate global and adequate regional flow, you may still have tissue hypoperfusion as a result of one of these challenging mechanisms. These also are static measurements. Dr. Hernandez mentioned some dynamic ones in his talk a few minutes ago, but these don't recognize things like pulsatile load, LV arterial coupling. So there's limitations in that these are static measurements. So anytime you pick up a resource, you look at a classification system and things we should be targeting, I would encourage you to take it a step further and think conceptually about the different layers of this, right? The macrohemodynamic, the regional effects, the microcirculatory effects, and the limitations of any data that we're interpreting. It may be unclear the best way to go about utilizing this data, but if we don't think about it, we'll never get there. It's also important to remember that we make this process more complex through our treatments, right? Every treatment affects SVR, every treatment affects flow and mean arterial pressure. Treatments affect ventricular contractility, be it pharmacologic or temporary MCS devices, right? So how we apply those, we have to consider the mixed physiology and the different phenotypes, which is the dominant phenotype, and how most effectively we can treat the overall picture. It's also important to recognize those global macrohemodynamic qualifiers are affected by these. A numerically normal SVR, for example, on a patient with 2 to 3 vasopressors is not normal SVR physiology, right? So understanding and remembering that as we're interpreting these values is critical to taking care of our patients. It's very easy to get lost in the noise of all that. I think it's important to step back and look at it more globally as we're doing all that assessment. And that is recognizing and considering what overall phenotype of mixed shock our patient might have. Some patients have a 2-hit approach where they either start with a primarily cardiogenic or primarily vasoplegic shock, and then through different pathways and secondary maladaptive processes end up in a mixed shock picture. That's different from a patient with a single hit model. Post-cardiotomy shock, for example, which you'll hear about next, or post-cardiac arrest patients, which are obese in and of themselves because of the profound ischemic reperfusion injury that occurs, and the fact that they get kind of a synchronous cardiac depression and vasoplegic process going together. Right? So considering where the patient starts and where you think they're evolving to can help us guide our decision making when caring for these patients. And the reason all this can occur is at the cellular level, many things can act as triggers for chemical pathways, right? Be it a lysed myocardial cell, those proteins that float around in the blood can activate the immune system, be it pathogen-associated molecular proteins from a bacteria. All of these can trigger cytokine release, and that cytokine release then activates enzymes, and those enzymes can result in toxic levels of nitric oxide. And that has many deleterious effects to the body, right? It causes microvascular dysfunction, oxidative stress, mitochondrial dysfunction. And so anything can act as a trigger that results in this secondary maladaptive vasodilation. So recognize at the cellular level what's going on with our patients and extrapolate that and expand it to how we're treating them at the macro level. I'll defer, getting into the weeds of every therapy because you'll hear about it extensively, but I'll make a couple of very brief points on temporary MCS. And that is, it's not the flow of MCS or the flow of ECMO that's the challenge here, it's the flow of data, right? It's still unclear exactly the best way to apply MCS to patients with mixed shock, but I'll stress that the best patient population to apply it in are those whose primary phenotype is cardiogenic. You cannot treat vasoplegia effectively with flow, okay? There's many forms, as we all know, of mechanical circulatory support. Theoretically, the best is going to be the higher flow biventricular support modalities like VA ECMO, including Impella as well in that mix, depending on their initial phenotype of the cardiogenic component. But recognize, even so, it often becomes very, very difficult to achieve enough flow to treat patients with a profound vasoplegic component to their shock. All right? There's different approaches with VA ECMO that can be utilized. You can use hybrid modalities where you add additional drainage cannulas and try and increase flow through a native circuit. You can add dual circuits in parallel, although those are ripe with complexities and additional challenges. So this is where the shock team approach becomes critical. Okay. So to summarize, key takeaways, remember to treat the phenotypes, not the initial label or classification. And in order to do that, we have to recognize the presence of heterogeneity, and the most effective way to do that is to leverage early invasive hemodynamic monitoring. We have to utilize that to match our interventions to the dominant mechanism, but we cannot forget or exclude the coexisting mechanisms when treating patients with mixed shock. Mixed shock will evolve. The hemodynamics of that patient will evolve, and our treatments must recognize and evolve with that. And finally, remember at the forefront that escalation is a signal of potential multimodality issues. It's not a definitive plan. Thank you.
Thank you, Dr. Stewart. The next speaker is Dr. Nate Earhart from Bay State Health System in Springfield, Massachusetts. He's talking about post-pericardotomy shock and pathways to recovery.
All right, I'd like to thank everybody for the opportunity to come to Tulsa and be a part of this great conference. Like you said, I'll be talking about post-cardiotomy shock and pathways for recovery. The objectives will be to first define post-cardiotomy shock, to move on to identify risk factors associated with this development, to review management strategies with a focus on timely initiation of MCS, and then to understand the role of different MCS modalities in the treatment of post-cardiotomy shock. So, like all shock, it's a spectrum. Low cardiac output syndrome is a reduction in cardiac output after cardiac surgery that really leads to inadequate systemic perfusion, and these patients typically require pharmacologic support. These patients have a low cardiac index, they have elevated filling pressures, but signs of shock still may be very mild or evolving. So these are like our SCAI Class B or early Class C patients, and they respond initially to inotropes, pressors, and volume optimization. But we have to remember that they're at very high risk of progressing to shock. Post-cardiotomy shock are patients who we cannot separate from cardiopulmonary bypass after cardiac surgery, or they have persistent cardiogenic shock despite maximal use of our pharmacological agents. These patients are hypotensive, they have signs of end organ dysfunction with AKI or liver injury or altered mental status, they have rising lactates, and once again our inotropes and pressors are failing. And this is a highly fatal condition with a 60 to 70% mortality, and that's despite all of the advances that we've had. Risk factors for low cardiac output syndrome and post-cardiotomy shock. You have patient risk factors and you have technical risk factors. Patient risk factors are patients that come in with a pre-existing MI. They may be older. They may have comorbidities such as obesity, renal insufficiency, diabetes, or they may be undergoing emergency surgery. Technical risk factors include patients who had inadequate myocardial protection during a cardiac surgery. They may have had iatrogenic myocardial ischemia during the operation, or they may have undergone an operation that required prolonged cross-clamp time and cardiopulmonary bypass. This is data from the STS showing really that we are operating on sicker and sicker patients. 10 to 15% of our CABG patients have an ejection fraction of less than 35%, and we know that these patients have higher mortalities. Patients with an EF of 25 to 34% have almost a 5% rate of mortality, while patients with an EF of less than 25% have a 7% of mortality. The risk of low cardiac output syndrome and shock varies by our procedures. You can see the more complicated the procedure gets in general, the higher risk they are of developing this. Isolated aortic valves have an incidence of around 6%. Our CABGs, like I said before, incidence of around 10% of low cardiac output syndrome. And then CABG mitrals are the highest with an incidence of almost 30%. So how do we manage these patients? Like I said before, first line of management is inotropes. So inotropes can help us at least initially increase cardiac contractility. They help us improve perfusion pressure in our patients. They can be rapidly titratable, and they really allow us some time to identify and correct reversible causes. Limitations are significant. They do increase myocardial oxygen demand. They can be arrhythmogenic. They can lead to splanchnic and peripheral perfusion difficulty. And we know that the higher dose of vasoactive inotrope score, we have a higher level of mortality. So really, this is where we need to start thinking about temporary mechanical circulatory support. And the theme of the day is that recognition and early escalation is critical. Delays, like I said before, can lead to worsening end organ dysfunction, increased pressor requirements and inotropes, and increased mortality. And we do have plenty of data now that shows that we have improved survival with early MCS initiation in these patients, particularly when we institute it intraoperatively or before progression. So these are the devices that we have at our disposal. For RV support, we have the Tandem Heart Protect Duo Impella RP. LV, we have the balloon pump Impella CP in 5.5 and the Tandem Heart LVAD. For biventricular support, we usually rely on VA ECMO. It's important to remember that these devices are temporary. They offer short-term hemodynamic support from hours to weeks, and they're be used as a bridge to recovery, hopefully, but also to decision or durable platform, such as an LVAD or heart transplant. The first device that we actually use a lot of in the operating room is the intra-aortic balloon pump. As most of us know, this device works based on counterpulsation, so the balloon inflates in the aorta during diastole and deflates in early systole. This leads to increased diastolic pressure in the aorta, which helps increase coronary blood flow to the heart. It also has a modest effect on afterload reduction in the LV, but a very small effect on increasing cardiac output. Advantages, like I said, afterload reduction, increase in coronary perfusion. It can be placed relatively easily in the operating room with percutaneous access. We have to think about the disadvantage. So like I said, you really have a minimal increase in cardiac output in most patients who are in shock. You are not actively unloading the left ventricle, and balloon pumps can limit ambulation. So what do we know? What evidence is out there regarding the use of balloon pump in these patients? Really, we know that patients who require rescue balloon pump after cardiac surgery have not only a significantly increased risk for short-term survival, but also one-year mortality. And once again, that's because this device really relies on the presence of sufficient contractile function of the heart to augment cardiac output, and it does not actively unload the LV. The next device we use is VA ECMO. This is the pros of this device. It offers full biventricular and respiratory support. It can be deployed quickly and pretty much anywhere in the hospital, and really no complex imaging is necessary, at least for initial placement. Cons, it has a high complication rate, which I'll get into a little bit. It does not unload the LV. These patients can be prone to north-south syndrome and differential oxygenation, and VA ECMO patients have limited mobility as well. We use two different types of cannulation strategies. One is the peripheral approach. It's important that we use a distal perfusion cannula in these cases to prevent limb ischemia. And it's important to think about LV management. We have to anticipate the increase in afterload that peripheral VA ECMO is going to cause. So we need to think about an early unloading strategy, such as a balloon pump or preferably an Impella 5.5. In the operating room with patients who we can't get off of bypass, this is the cannulation technique that we most often use. It's central cannulation. The advantages of this are that we can achieve antegrade flow in the ascending aorta. We can achieve higher flow rates with bigger cannulas, and these patients have a lower risk of differential oxygenation because of that. Disadvantages are significant. These patients are often left with an open chest, and this leaves them at high bleeding risk, higher infection risk, and they also have a higher stroke risk. This is data from the ELSO registry showing the incidence of complications of ECMO. You can see that cannulation site bleeding occurs in 12.5% of patients. Surgical site bleeding, about the same. Limb ischemia is a big one that we really worry about. It's a hugely morbid condition. It occurs in at least 5.3% of patients with peripheral VA ECMO. So the data regarding VA ECMO for post-cardiotomy shock shows that these patients really have a dismal survival. Mainly it's because you're not doing any favors for the LV. ECMO increases LV afterload, and this has detrimental effects. It increases myocardial oxygen consumption, stroke work. These patients can develop LV thrombi, aortic valve stasis, and even root thrombus. And because of the increased afterload on the LV, they can develop pulmonary edema. And like I said before, they have a very high complication rate, reoperation for bleeding, kidney failure, and stroke. That brings us to the Impella 5.5, which is a percutaneous microaxial flow pump. It's a device that provides up to 5.5 liters per minute of flow, and this really enables complete LV support in these patients, and also acts to restore end organ perfusion. The advantages that the Impella has over our other devices are mainly that it provides direct mechanical LV unloading with relatively high antegrade flow. We can provide longer duration of support in these patients because it is placed in the peripheral position. And because of this, we can also mobilize these patients and rehab them. This is how we usually place it in the operating room in a patient who we think is at risk or has developed low cardiac output syndrome or post-cardiotomy shock. We sew a graft onto the ascending aorta. It's tunneled out through an incision right here, just above the clavicle, and the device is inserted through that graft through the ascending aorta into the LV. There's a lot of excitement about the use of 5.5 in these patients currently, and there's a growing body of evidence that's out there. Right now, it is limited to case series and case reports. And this has really brought out the idea of protected cardiac surgery. The European Association of Cardiothoracic Surgery recently released an expert consensus model on this topic, discussing protected cardiac surgery. And they talk about 3 different types of patients. Type 1 patients are our bridge to surgery patients, or preoperative use of temporary MCS. These are patients who come in with very high risk. They may be in cardiogenic shock with refractory acidosis. They may have experienced cardiac arrest. They may have a mechanical complication of MI, such as a post-MI VSD or papillary muscle rupture with acute MR. Or they may have overall severely reduced uni or biventricular function. So in these patients, the Impella is introduced before surgery, they're prehabbed, and when they improve, they become much better surgical candidates. Type 2 patients are where we plan intraoperative temporary MCS. And these are also high-risk patients who we think are high risk for developing low cardiac output syndrome after surgery, and we want to prevent that. So once again, these are patients who may have developed cardiogenic shock. They may be patients who we are unable to completely revascularize during a bypass operation. They may be patients who had suboptimal cardiac protection during the case or had prolonged cardiac ischemia. The type 3 patients are patients with unplanned intraoperative temporary MCS. And these are patients who are weaning off a bypass. They may have very high inotropic requirements, also suboptimal cardiac protection. There may have been an iatrogenic injury during the case, or the case may have failed for some reason. So the MCS device is initiated in the operating room, once again, prior to weaning off of cardiopulmonary bypass. The same authors of these guidelines proposed this algorithm where these patients are assessed by a multidisciplinary team going into the operation. If they're deemed to be acceptable candidates, we assess them for any signs of shock or end organ damage. If not, they can proceed to cardiac surgery with MCS standby, so they'd be more like a type 2 patient. And if so, then if they do have signs of shock or end organ failure, we consider preemptive temporary MCS where the device is inserted. They're given a few days, maybe even a couple of weeks to prehab before their high-risk cardiac surgery. This is the IMPACT study, which is actually being presented later today in Chicago at AATS. It's a multi-center prospective single-arm trial looking at the safety of Impella 5.5 in these high-risk cardiac surgery patients who have severe LV dysfunction. So these are patients who are undergoing CABG with an EF of less than 25%, or combined CABG mitral with an EF of less than 35%. So our highest risk patients going into the operating room. And they're looking at the effect of putting in an Impella prior to weaning off cardiopulmonary bypass. And they're going to look at the rate of postcardiotomy shock at hospital discharge, and then other safety endpoints, including all-cause mortality, stroke, and new requirement for renal replacement therapy. So we're all excited to see the results of this study. Like I said, it has been completed. There's also a study going on in Europe that has been completed as well. So to conclude, postcardiotomy shock has a very high mortality rate, up to 70%. It is a spectrum progressing from low cardiac output syndrome to refractory circulatory failure. Outcomes to date have not significantly improved despite our better technology, and we need better ways of thinking about it. And really, it's our shift of thinking that needs to happen. The traditional approach with our low cardiac output syndrome patients, putting them on inotropes, adding more inotropes until they crash, they're put on ECMO. These are very sick patients, and we know that our outcomes aren't good. I think the theme of the day today, like I said before, is really identifying these patients early, anticipate their low cardiac output syndrome patients' shock, and initiate early or preemptive even mechanical circulatory support. So thank you.
Thank you. The next presenter is Anderson Murley from Bartlesville, Oklahoma. He's a cardiologist there, and he has a case to present.
Thank you, Dr. Garrett, and good morning. As we wrap up session 1, I think this case is a great example, and I hope you all will see the multiple interactions that it takes along the way to hopefully get somebody to survival, highlighting the importance of collaboration, highlighting the decision-making that takes place, the work involved, and then ultimately what we all hope to see is walking out of the hospital. So thank you for letting me share this case with you. Let's see. Now, in Bartlesville, so where I am, this young man traveled all the way from Nashville, and 61-year-old, and not just visiting, but playing with his band, concert, touring perhaps, no cardiac history, no warning that he was given before the travel. And then in June of last year, setting up for his concert, experienced sudden cardiac death, dropped dead. First interaction with healthcare, and bystander recognized what was happening, not only performed CPR. Imagine if there's no AED there, right? There was, and he had his first successful, again, this is so multi-pronged approach to survival, right? First interaction, AED was applied, received a shock, ROSC occurred, the patient was then picked up by EMS and in the field there in transport to Jane Phillips, our local hospital. There was ST elevation. STEMI protocol was activated early. People are getting prepared. Teams are coming in. When he arrives in the ER, he's still awake. He's alert. He's not doing well. He's vomiting, very sick. They are still performing CPR en route and even in the ER. Okay. He gets shock is recognized early on, and we prepare in the cath lab for what we might be in store for. I mean, in the cath lab. In the ER, they've already given heparin. Once the patient was stabilized enough in the ER, then we quickly transport him to the cath lab. You can see what we anticipated is reality, and his left anterior descending artery there, highlighted with the arrow, is occluded. His ST elevation also was in this distribution. Wire was passed. It's not a chronic occlusion. This is a fresh occlusion that set off this cascade this morning. And then after 2 stents, the result here, we've restored flow. Now, I'll back up just a little bit. The patient had very early signs of shock. right? You saw some of them listed on that previous slide. And there's a decision-making points all along here. When do we place support devices? What comes first? Do you restore the flow through the coronary, or do you support during the case? I think it's this is a common decision-making point, and can be discussed here if there are questions that arise. What we decided to do at the time was restore flow through the coronary, but the lactate came back about that time. It's 4. It's hypotensive still in the cath lab, so at that point we initiate support. There's stabilization enough, and we call St. John Hospital here in Tulsa. Our regional hospital is not equipped for the intense management as highlighted so far today that it takes to bring these people to survival. So after stabilization, placing the PA catheters, things like that really, need to be done for stabilization, and then you transfer, right? Sometimes you can't wait to get them to a tertiary center to supply this kind of support. So the networking, the education that it takes, the protocols, all that takes place in your satellite hospitals really is just as important. So we were able to initiate the stabilization and transfer to St. John. Sky Class D, increasing pressures requirements and rising lactate. They wanted to escalate to a 5.5. On the next day, 6.13, failing to improve, signs of RV dysfunction as highlighted by some of the previous speakers. And now he's on the ventilator, and the thought was, okay, what kind of escalation, what kind of plan, what's the next step? And they reached out to to St. Francis, who agreed that perhaps ECMO is the next step, and Dr. Phillips cannulated at St. John and then transported to St. Francis. St. Francis, with the intensive management by some of the speakers that you perhaps have heard today, there was improvement. Chest X-ray improved over a couple of days. The echocardiogram showed the RV function was improving. The numbers improved. So decision-making points. The decision was made to try to decannulate from ECMO. They got rid of the 5 Impella CP, placed the 5.5, and then were able to extubate about 4 to 5 days later. And then, as you saw in the picture, it's amazing to me that these people can ambulate with the support device in place. But as you know, you think, hey, be still, lie down, let's let you rest. Instead, a lot of the focus on early ambulation for better recovery. So by 6:26, he was off drips. His EF looked to be around 40%, and the patient was discharged July the 3rd to go home to Nashville. Now, interestingly, right, the story can't stop when he leaves the hospital. There's also collaboration afterwards, and there's been follow-up since 9:30. He had his first visit, was improving, actually performing with his band again. In November, he had an AICD placed, and the most recent follow-up in January is doing well with minimal symptoms. So as you can see, not only the work involved, the collaboration that it takes, the decision-making points along the way are really integral to success, which fortunately this patient had a great outcome. So thank you. Yeah.
Thank you. 15-minute break. The next session 2 will begin in about 15 minutes.
Just before that, because we're all here,
We're
we can probably just do maybe 2 or 3 questions if that's okay with you,
Sure.
Bob. Granted that we have a little bit of space during lunch to be late. Just want to have a question, and maybe the whole team can answer that is here in the panel, and then maybe a question from the audience. I think, that is a beautiful example of regionalization of care, and I think we all come from different backgrounds and experiences we have hubs and spokes, but, from your perspective, and happy to hear different thoughts, we can just go around. Is there a role for having a network of care in which data is shared between centers not by system, but perhaps by geography, so we can have a little bit of more situational awareness about these cases? Do you think that we're far away from that, or it's just more of creating access at the hub and then just see whatever will be sent from different spoke hospitals? I mean, I'm just interested to know what happens in Massachusetts. You know, Ali make a beautiful example in Oklahoma, and you guys have the perspective here in Tulsa. But I think, you know, with these examples, it's definitely a human component and there's a system component. And I think when you have the combination of both, that's when, you know, beautiful outcomes happen, like the one that Dr. Merle just showed. But overall, how can we represent that in every single case so we can create equity and we can be more, you know, scale it to all the patients that are in need? So I don't know, what do you think?
Yeah, thank you. It's so important to discuss. Coming from Massachusetts, Bay State is a regional medical center in western Massachusetts, really the only big hospital in western Massachusetts. We have a very large cath lab. So we take patients in from the western side of the state, but also southern Vermont, northern Connecticut. So I think that outreach is very important. Education for these smaller hospitals that we collaborate with. Not only do they need to know what we have available, but they need to know how to engage us early and help these patients early on in their course, so we're not getting them late on when they're the sickest and the most difficult to treat. So outreach, education, and then making it easier for them to communicate with us, I think is very important. And that's, I think, one of the biggest challenges in initiating regional shock systems.
Well, I would thank you. I would echo that. That's really outreach and education is a very important point. Also to understand that the offer that as a service, because that's important for us. That's something we are not learning as a doctors in medical school, that to offer that as a service. We had somebody calling me from outside hospital. He or she have a problem with the patient, have stress. And if you take that burden from them, they are thankful for that. And that's even sometimes we got punished because you accepted patient, which might be the outcome or the exit strategy is not clear. But in a process of building the network, you have to accept such kind of cases at the beginning, and then we learn from that. Both of us learn from that. I learn from that, also the repairing center learn from that. And to be available 24/7, that's something is, we have to be and offer as a service, one phone call, accept the patient here. Data sharing now sometimes is tough if you are approaching outside, hospital outside your system. Is not easy to get. If that's we're working now in like Baylor, you guys are a big system and interconnected, you might easy to get that data. But if you're now accepting patients from outside your system, it's tough to get the real data to help you to manage or to accept or not to accept this patient, and even for research and moving forward.
Yeah, I would stress the key is an effective and efficient way of two-way communication. Coming from Seattle that had a very large capture area across many states, there was ongoing joint education that served the primary purpose of that, because I think it's just as important for the education for the spoke facilities as well as feedback to the receiving facilities and inefficiencies in the process regarding transfer and how most effectively to do that and provide that support consistently to patients.
I would agree. This is an incredible example of what can be done in this day and age with heart failure. For sure, this patient was transferred twice, which is an amazing thing as well. It's communication, it's developing relationships in the region, making people aware of what can be done, what should be done, and experience is important too, because sometimes these people deteriorate very quickly. So speed and communication are very important. But Dr. Merle deserves a lot of credit for saving this guy's life. He really does. So, how good was their band? Was their band pretty good?
I wish I could hear them play. I will just echo a couple of things from that side. Isn't it interesting the barriers that exist that are non really medical, and to get data, to interact, collaborate across systems. It's harder now than ever. Hey, keep it in network, so on and so forth. But this is an example of what, hey, this goes beyond hospital systems, beyond geography. What does it take to save a life? And then you start thinking, okay, what are our possibilities to collect data and interact and create a system that collects all this data? So that I think this case highlights that, and I hope we can get past some of those barriers. And then the last part of it is let's not forget the importance of CPR, AED placements, things like that should start like in high school or some, and how important that is, because that's where it all started for this patient. Thank you.
Thank you. I think one important thing I would like to add is the feedback. I think talking to each other to see how we can do better. Because if we're not hearing what you want and how we can serve you in a better way, we're going to have only one-way street. That way, it's a two-way street, to get feedback about your patient and also listening to each other, we learn from each other, and we'll give you feedback about the outcomes of this patient. That's very important to get the partners in our network, how they are performing and how we are performing.
The value of human connection versus everything else, right? So congratulations again, and thank you so much for coming and sharing that. Any questions from the audience? Maybe one more question or comment? Rachna?
I can do a question. Maybe for the surgeons, intensivists, right? We talked about mixed shock. We talked about post-cardiotomy shock.
I just want to say, Rachna Kataria is a part of the steering committee of the cardiac shock working group. She comes from Tufts in Boston, and she's a leader in cardiac shock. So we're very happy.
We need direct flights from Boston.
So,
If anyone has any influence or control over that. But so for post-cardiotomy shock, we talked about LVEF. We talked about identifying low cardiac output state. In your practice, do you recommend, prefer to have a more nuanced, like hemodynamic profiling pre-op? Does it help you with post-operative outcomes and management? Do you recommend it in every single, how do you pick and choose?
So it depends on the patient. Certainly a high-risk patient coming in with signs of shock, I'd love to have a PA catheter. And the help of my cardiology and intensivist colleagues to optimize that patient medically for the operation. But it's a combination of things, comorbidities, hemodynamics, the type of operation we're going to do.
Well, I think it was a great session. I want to add it on just asking this with the surgical cases specifically. I think one thing which is very important is the center which is doing these surgeries, right? We can go and retrieve and go and bring a patient on an OR when patient is crashing, but I think as a surgeon, it's equally important to determine where these surgeries are done and what platform are we able to perform high-risk complex surgery. Do they have a backup available, or at least they have talked to a center where backup is available? A simple example, especially I want to take a surgeon viewpoint, is that many of these heart failure patients, their preload makes a big difference before going for surgery. I personally prefer that if their CVPs are high, they don't do well. And we know that from our VAD transplant world. But when these people go for surgery, sometimes I realize they don't have any hemodynamics. And when they come crashing out, that's when we're realizing that these things will be done. So I don't know what your experiences have been when you are collaborating especially with outside networks, surgeons, of managing these kind of patients if they are doing surgeries in their hospitals, and how do you come about with that, and how do you decide and how we can support them?
I mean, it's important to have a multidisciplinary discussion for high-risk patients before they go to the operating room. I think we're very good at that at Bay State. If one of the surgeons has a patient, we have a high-risk heart team meeting on that patient, usually within the same week, and we can all go in our plans in mind of how we're going to handle difficulty. So I think that's really what we need. We need to involve our colleagues in making decisions for these patients. And the decisions need to be made before we go to the operating room. We need to plan for this.
No, you had something.
I would agree. We're all still learning. The surgeons are learning. The heart failure specialists are learning. the way to look at most of these tools is that they are a tool. They're not it's not a failure to use them. And it's so much better than intrahec balloon pump now that a lot of times for high-risk people, we'll put them in preoperatively to optimize them for surgery. That's ideal. There's a lot of times now we'll put a graft on the aorta so we can easily put it in at the immediate perioperative period. And it's a great tool. You can certainly do higher risk people than you could. There are still times I think ECMO plays a role in post-pericardotomy syndrome, particularly if the RV is failing, which is pretty common in major cardiac surgeries, high-risk surgeries. So it involves planning, it involves learning. A lot of surgeons are kind of lagging behind in using the Impella and tools like that. But I think over time they'll learn it's a good tool and it's not a failure to use those devices.
Yeah, I mean, from the perspective of, that team, I think we are all learning, and this is probably translated from the transplant and BAT relationship between the heart failure ICU team and the surgeon, in which we know we are preparing that patient to have a great operation. So we feel accountable if the patient's going to the OR and, their RA pressures are 20 and, they're having increased bleeding and oozing and right heart dysfunction. So I think the new era that we're seeing, and I think thanks to Ali and Bob and Doug and the platform that has been built, is that we really are all accountable for the same outcome. We're not really thinking about, well, they're just transitioned to surgery and we'll see what happens. It's actually, we want to make sure that the patient is going to the OR and when anesthesia receives the patient, he's at the best hemodynamic state with the best end organ function possible. And that relationship then creates, I think, a better platform for having more surgeons involved in that process, to having more team members involved in early referrals, and just to see that it's a continuum of care. It's not really just one single event surgical-wise, and it's the whole process that really affects us. And we really want to make sure that patient has a great CABG, for example, so they don't need to have an LVAD right away, or 6 months or 1 year down the line. So all these decisions, I think, the more that we do them together, I think it's going to just benefit the patients that we serve. So break, and
Break time,
maybe
yes.
10 minute
Yep.
break, and then we can come back in 10 minutes. Thank you.